So for me, health in Africa, I think, is a story that is half told. There's the half of the story that we know very well, that is driven by several narratives. And then there's the other half, maybe a third, maybe 3/4, maybe, I don't know, 20% that we actually don't know, and we could know. What we know is driven by three main narratives. We count health in terms of death. So how many people died, how many women, how many children, who died of what? That's a narrative that sort of dominates the health narrative. The death narrative is also driven by what kills people quickly. Ebola, for instance. If it's not Ebola, it's malaria. Kills you very quickly, 3 days, 5 days, 7 days. It's a narrative that is, what will I die of? Will this Ebola cross the Atlantic? Will it come on the planes that land at JFK? So that sort of drives a lot of the narrative about health in Africa is driven by death and what people die of and what I may die of as a global citizen. The problem with that is that there's an assumption that you're not dead, you're healthy. And the deader you are, the less healthy you are. So we forget the things that will eventually kill you, albeit slowly, like non-communicable diseases. So dying of malaria and dying of renal failure as a result of diabetes, perhaps to the person that dies, it doesn't matter. Maybe for the person that dies of malaria, it's quick and short, it's 5 days. And maybe 2 of those days you don't even know that you're dying. But for the person that dies after 10 years of untreated diabetes, it's a long, out of those 10 years, perhaps 7 of them will be lived with disability, with ill health, inability to be productive, to do the things that people are supposed to do. The other problem with that is that we focus on some things are not others. So we provide bread. We have to deal with malaria. Not that I'm complaining, we have to. But then we forget other things. How about the air quality? We're building roads, highways. I come from Kenya, we just built a super highway that is 51 kilometers long. But you don't think about the air quality that is coming out of all these cars. I don't know how many of you have been to Nairobi, but you don't want to be in Nairobi on a Friday evening. At the end of the month, 10 kilometers takes you 3 hours, and you're inhaling fumes of poison. What about what we eat? So we focus on some things, but not on others. The second narrative, maybe a much more, not so pleasant, but less scary narrative. It's about diseases. We talk about diseases rather than health. So we focus on how to treat diseases, how to prevent them, rather than what is health? How do we generate health? How do we sustain health? How do we prolong health? How do we live long, healthy, productive lives? The third narrative is about vulnerability. We look at health through the lens of who is vulnerable, rather than who is resilient, who is healthy. And when you look at vulnerability, it means we focus on subgroups and not others. So the consequence is, what we know sort of drives what we do. The things we know about health in Africa defines the choices we make, the priorities we make about how to address health in Africa. So we treat diseases, and then we choose which disease to treat. And among which diseases, among which subgroups to treat. And we pay less attention to how to generate and sustain health. And we pay less attention to what systems should be put up to generate health and sustain health and serve everybody. We don't have to make choices about whether we should deal with women, or children, or their grandparents, or their parents. So why does APHRC come in all this? APHRC as an institution, you want the full story of health in Africa to be told. And how do you go about that? We want to align the narratives. We want what we know and what we could know, or what we should know, to align to each other, so that at the end of the day, we have the full story of health in Africa. And how do we do that? Of course, we talk about death. Peter mentioned it. We've done the infant mortality estimates. We've done the maternal mortality estimates. I can tell you that in Nairobi, at least until 4 years ago, the maternal mortality rate was 709 out of 100,000, compared to 188 in Kenya. We talk about diseases, we measure them. I can tell you that 1 out of 5 adults in Nairobi is either hypertensive or diabetic. I can tell you that half of the children below the age of 5 are stunted. So we do that. But what we are trying to do is we want to tell everybody's story. So our work cuts across the life course. We talk about children, we talk about newborns, we talk about older children, adolescents. We talk about older people. We don't want anybody left behind in the story of health in Africa. Other than that, we try to challenge the narrative. And we try to challenge common perceptions. As Alex just mentioned, we are trying to tackle issues that perhaps are not the issues of today, they're not the issues of now. And he just gave a good example about our work on urbanization. I can give other examples, our work on education. Education was supposed to be this transformative process, like a wave that swept across Africa around free primary education. Until we said, wait a minute, free primary education was a pro-poor policy. And Professor is here. I think he was as surprised as we were when we actually found out that over time, the poorest children in the slums of Nairobi are living in the public sector where free primary education is offered. And as time goes on, the poor children in the formal settlements, the planned settlements, are still in the public sector, but the poorest children have actually left the public sector for various reasons. The work on non-communicable diseases that Alex mentioned, it was about 5 years ago, it was very hard to convince anybody that it was important to know what is the problem of non-communicable diseases in Kenya or in other African countries. Until, unfortunately for Kenya, 2 of the former ministers of health fell in cancer. And our cancer is way up there. Yes, Professor will attest to that. Cancer is the only non-communicable disease that gets any kind of traction in Kenya in terms of attention to policy, in terms of the advocacy, the media. It's all about cancer. Do we need all the ministers in Africa to get cancer or to get diabetes, or to get strokes, before we can think about how important non-communicable diseases are? The other work we're doing is on aging. There's a common perception about how good it is to be an old person in Africa. There's respect, the grandchildren, there's love, there's support. Maybe not so. And our work on aging is trying to challenge those common perceptions, that as we have discourses about even the social development goals that are coming up, if we want to build the next generation of productive Africans, we have to think about the role of the older people, the intergenerational transfer in terms of knowledge, in terms of education, in terms of resources. We have to think about that. The work we are doing in population dynamics and reproductive health, we are telling the Kenyan government, you can hide your health in the sand all you want, but 500,000 women had unsafe abortions last year. You can, that's a fact. So what you do with that fact is up to you. You can pretend that unsafe abortion does not exist. You can debate on whether it's illegal, whether it's illegal or not. It's a fact. The other way we're trying to do that is we're trying to make the case for disease and death fine, but in a broader goal on health in Africa. And how do we do that? We're trying to be part of the solution. So we don't just define problems, we don't just measure them, we don't just measure disease and death. We're trying to do research that actually provides solutions. Solutions that include disease management, disease prevention, but also generational health. We have some projects that are looking at how do you reduce infant mortality. You do that by keeping adolescent girls in school. And how do you keep adolescent girls in school? You give them $120 a year to go to secondary school. That's what it takes. And then you avoid all these problems over unwanted pregnancy, and teenage pregnancy, and infant mortality, and malnutrition, and another generation of disadvantaged children. The question you may ask is, why does it have to be APHRC? It's APHRC because APHRC is a unique animal, if I could call it that, because you go beyond research. Somebody mentioned we don't just want to publish papers. We work with decision makers, we work with policy makers, ministers, parliamentary groups. We work with individuals, communities, implementing agencies. We work with them across the process of doing research. Sometimes maybe it's too late once the research is done, but we want the evidence that we have to actually inform decisions that individuals, communities, societies, countries, and the global community make. And as Margaret mentioned, we are very generous. we don't want just to be APHRC, a lone voice in the desert that is not going to be heard probably. So we are building a voice across Africa through our research capacity strengthening initiatives. And at the end of the day, we are assuming that there will be much more, it won't be just a half that is untold, perhaps it will be 10% that is untold, because there will be more Africans in many institutions that actually tell the same story, and coming up with more solutions for the problems that afflict Africa. But what makes us perhaps more unique is the fact that we are in it for the long haul. And having been in the same place for many years, our understanding of the context sometimes is not something we can put in a scientific publication. And I'll just give one illustration of that. As I said, we've done a lot of work on the health and well-being of people in poor informal settlements, especially in Nairobi. And some of this work has, as I said, has shown that maternal mortality is very high, 709 out of 100,000. So some person read our research and said, I think we can do something about this. And they designed a program on what they call output-based approach, reproductive health vouchers. And how that works is very simple. The poorest women in these settlements buy a voucher at 200 Kenyan shillings, that's about $2.50. And this voucher entitles them to 4 antenatal visits at an accredited institution. That means it has the right quality, the right staff, and all that. It entitles them to delivery, whether it is normal delivery, whether it's a cesarean section, emergency transportation, everything, just by buying that one voucher. People can actually access these services. So it's a successful program. But then some of the work that we did showed that actually 30% of the women that had bought these precious vouchers delivered at home. And the question was, why would somebody spend their hard-earned $2.50, buy this voucher, and still have a baby at home? And it was very simple. It's because if you get into labor at night, in the middle of Kyobutungi slum, it will be seen quite soon, it's a question of whether you want to risk getting mugged on your way to the hospital or to risk having the baby at home. And many women, they choose the option of having the baby at home. They don't want to be starved or mugged or worse still, raped when they don't have a baby. So the women actually stay at home. So having been in this place for quite a long time, what we've said is there something else you can, what value can you add? Because you've removed the financial barrier, what value can you add? If the issue is security, security is a community issue. It is caused by the same community members. So you're working with youth groups who are acting as security escorts. There's a whole network of women, community health volunteers, and youth groups. So when a woman gets into labor, there somebody on speed dial, and a group of 6 energetic young men will come and escort this woman to the nearest health facility where she can have a baby. And like I said, this has been going for the last 3 months, and 55 women have actually been escorted by this network of young men and women. For the young men, it's an opportunity to give back to the community. For the women who have had to go through this process, their lifesaver. So sometimes that's what it takes, that you've been there in the long haul, you've understood the context, that there are certain nuances that perhaps could add value to some of the initiatives that are also trying to help and generate health in these communities. So in sum, Alex said that Africa generates less than 1% of the global knowledge. Can we imagine if there was no APHRC? But better still, can we imagine if there were 10 APHRCs, or if the impact of APHRC was amplified 10-fold or 100-fold? Can we imagine if the full story of health in Africa was told? How much more impact it would have?